Dr. Furst is internationally known for his expertise in the research and treatment of scleroderma and rheumatoid arthritis. He has specialized in studying how medications react in the body to treat rheumatic diseases. He is a member, master, and fellow in the American College of Rheumatology. Dr. Furst has published more than 330 book chapters and reviews, 366 peer-reviewed research articles, and edited 17 books, including 2 editions of a textbook on scleroderma. He lectures and teaches internationally as well as in the US, and Dr. Furst's area of research besides scleroderma is rheumatoid arthritis, polymyositis, and dermatomyositis. Dr. Furst is also the vice president of the Scleroderma Foundation, and as you know, he and his wife have done numerous talks over the years for the Scleroderma Foundation, for patient education days, for support group meetings. And we can't thank you enough for all of your support. And knowing that we needed this information today, Dr. Furst, in a second, guys, we reached out to him and said, can we do another talk? We're getting a lot of questions from people, and he agreed. And with this busy schedule that he has, we are very, very thankful and appreciative of your time and your efforts today. So welcome, Dr. Furst.
All right, we'll try again. So thank you so much. And as I said, that was a wonderful introduction. My parents would have loved hearing it. So let's get started. Emmanuel, could you share the screen? Okay, and here we are. So today we're going to spend our time talking about COVID-19 vaccinations and the things associated with it. Next slide. I have a number of disclosures. I work with many companies to do my research. Next slide. Right away, there has to be a spoiler alert. By the time the talk is over, it's already going to be behind the latest data. As a matter of fact, 5 minutes before I got on, I came across another article that I'll discuss. So this is an ongoing issue, and it's a good one. Next slide. I want to talk about 11 different questions that people ask. First, I'm just not sure about whether I should get the vaccination. SARS-CoV-2 is just another virus like flu, isn't it? Second, should I use the rapid home test to diagnose COVID-19? Third, if I get COVID-19, what should I do about my scleroderma meds? Next slide. Can I get COVID-19 from any of the vaccines? There are so many vaccines. Is one better than the other? These are things people have asked me. That's why I'm bringing them up. I want to do normal things. If I get vaccinated, how long will I be protected? And then, very important one, how safe is the vaccine, both short and long term? Next slide, please. Onward. If I've already had COVID-19, do I need vaccination? And can the vaccine cause my disease to flare? Will it work if I'm immunosuppressed? And when I'm being vaccinated, do I need to stop my meds? And we're trying to cover all of those things. Next slide. We'll start with this one. I'm just not sure about whether I should get vaccinated. You know, SARS-CoV-2 is just another virus, isn't it? Next slide. Well, you know, these are legitimate concerns. And there was a survey of 1,300 or so rheumatic disease patients. Most of them had RA or lupus, but 37% had others. We don't know what they were. This was a web-based survey. It was in the Netherlands. And there were about half as many controls, 682. And they were from the health fields. Turned out that 39% of the patients, 35% of the controls were undecided or unwilling to be vaccinated. You can see what their patients were like. They were mostly women and age 56. At the end, it turned out, and we'll talk about that, but it turned out that males and people who are older were more willing to take the vaccine. So what were some of the concerns? And you can see them there. First, many patients were really worried about the adverse events of the vaccines. I don't call it that actually, I call it adverse effects. And many of them were worried about the lack of long-term research. These are very legitimate concerns. One of the things that was a surprise is many of them were using biologics. None of them brought that up as a concern. And when they asked what might change their mind, they said that those who were undecided said that they could be persuaded by their physician. 69% of them said that. Those who were unwilling rather than undecided, only 31% could be persuaded by their physician. So there were very legitimate concerns, and there were some who were willing to listen, not all. Next slide. So what about COVID-19? Is it just another flu? It is a viral illness after all. Next slide. One of the things that made it different is that they had venous thrombotic events, clots. In this study, it was about 2,400 patients with autoimmune disease. And they looked at a huge number of comparators. One thing that was found was that compared to those who did not get COVID-19, there was no increase in mechanical ventilation or deaths in those with autoimmune disease. But the thrombotic events were increased. You can see some of the other things that looked like they would be up, but weren't. Hospitalizations, 14% increased. ICU admissions, 32%, not statistical. Respiratory failure, 7%. So it looks as if one of the differences is clots. Next slide. And what was associated with that was autoimmune proteins that made clotting more likely. These are called antiphospholipid, APL. And in those patients, 52% of the patients had some of these predispositions to clots. And you can see it on the right. And it's not important, but there are a whole bunch of them. And altogether, more than half of the patients with COVID-19 have a tendency towards clotting, at least in the blood, not necessarily clinically. Next slide. And if you look at the predictors from the electronic medical record, the EMR, and this again, a large number of patients, 31,000 patients in the US, the things that predicted death was older age, which doesn't come as a surprise, being a male, being a Black or African American, having cardiovascular disease, that is a heart attack or congestive heart failure, having CNS or brain disease, dementia, having chronic lung problems, under background chronic lung issues, and having liver or kidney problems. So you can see it covers darn near every comorbidity, comorbidity being some other illness beyond the COVID-19. So the heart, the brain, the lung, the liver, and the kidneys. Next slide. There has been some work done in scleroderma. This is a study that was, well, it isn't actually published yet. It was 178 patients followed for about 6 weeks who had COVID-19. And a couple of things come out. First of all, in these patients, the outcome was worse than in the normal population. That's severe outcome. In addition, unfortunately, patients who have scleroderma have higher incidence than the background population. In background population, it's around 10 or 11%. The things that trended towards having that is lung problems. You can see the DLCO, immunosuppression, and heart problems. They weren't statistical, but the numbers aren't that great. So those might be the things that predispose people to get in trouble if they have scleroderma. Next slide. This is a somewhat complicated slide, but it really is interesting. Each different color represents a state. And it was broken up into the New England and Northeast, the Southeast and Southwest, and then the Plains state in the West. The Great Lakes, I have no idea where that's there. But what you can see is this is the number of deaths beyond what would happen normally if there were no pandemic. So they found what the rate was for, let's say, heart disease or cancer or kidney disease and subtracted that. So these are all excess deaths. And what you can see is a couple of things that are very important. In the North, in New England and the Northeast, where they were very stringent, there was this first peak, and then they were really stringent with lockdowns and masks and so on. And you can see it remained very low, even with the peak towards the end of the year. In the West, which is C in the bottom, you can see that there was a little less stringency, and so there were more deaths. And then in the Southeast and Southwest, where really people were very much less careful, there was clearly an increase. And what this tells me is that whatever else we do, we really need to continue to be careful about some distancing, some washing of hands, and particularly the masks. So we know it's more dangerous for patients with scleroderma, but this is one of the things that can really make a difference. Next slide. So in summary, there are legitimate concerns among those who hesitate to get vaccinated. And no, SARS-CoV-2 is not like the usual flu. Next slide. So having dealt with the first question, the second question that people ask is, should I use the rapid home test to diagnose COVID-19? Next slide. Now, there's a bunch of tests, and we have to kind of get a background on this. First of all, there are the nucleic acid-based tests. That's the ones you've been doing all along with testing up the nose. And it looks at the viral RNA. It isn't the whole virus, just the RNA. The FAST test is what's called the antigen test in the middle. And what it does is it has antibodies against the surface antigens. Again, not the whole virus, just the spike proteins. And then there's the antibody test, which has to be done in the blood. And it examines whether the body has made a response to COVID-19. Next slide. In one case, the nucleic acid, what I will call PCR, you get a nose swab or a throat swab. It's extracted, converted, and then replicated enough times so that the machines can measure it. That number of replications is a reflection of how few viruses are there. If you have to have a lot of replications before it can be measured, that means there were very few viruses. And we'll get back to that. That's called the CT. Higher numbers means more replications needed, and therefore a lower body load. Then the antigen-based, or the FAST one, is also through the nose or throat. And then it's put on a little a slide where you can actually look at the results, kind of like a pregnancy test. And then the blood sample is necessary for the antibody test. Next slide. What are differences? Well, the nucleic acid tells you whether there's any viral genetic material even at a low level. It does not say the virus is there, just genetic material. It takes hours, usually days actually, to get it back. And it's pretty darn expensive, but it's very sensitive, very specific. The nasal or rapid test gets your response very quickly, but it really isn't very good unless they're high concentrations. So it misses infections. And the antibody test doesn't tell you whether you're infected, only whether you had been infected. It can be done very quickly. It can be very cheap, but there are some hangups with this one that we'll go over. Next slide. So how does this work? The orange line gives you the amount of viral material around. So during the infections, there's a lot of virus. And then after the infection, it gets cleared gradually. And the rapid test requires the number of viruses around that you see with the line that says low sensitivity rapid antigen. And there can be much lower concentrations to be picked up by the PCR test. Next slide. So what are these antibody tests all about? Next slide. What you're looking at here is a complex picture, but it's really very illustrative. In the background is the spike from the virus. And on that spike, there are a number of antibody receptor binding sites, RBD, receptor binding domains. So there are 4 different ones, and they have different names and all sorts of things. But the point is that if these are blocked, then the virus can't attach. And so if you have an antibody, then it can pick up whether those the spike has these places on it for attachment. So antibodies attach to these various sites. Okay. If you block the receptor binding domain, you're treating the disease because the bug can't get into the body, into the cells. Next slide. So what actually happens? If you look at the orange line, what you see is that the antibody becomes positive pretty early. Look at the bottom. This is the days. And it becomes positive pretty early, and it hangs around very nicely for 50 days, and then slowly it goes away because it isn't needed anymore. And by about 6 months, it's pretty much gone out of the system. It's important to know, which it means that, as in any illness, the body needs the antibodies less and fewer of them around. And by 6 months or a little bit more, most of them are gone for any given illness. Remember that 6 months number. Next slide. But it's not all the same. These 4 lines represent 4 different antibody tests. And you can see that when the CT value is high, that is, the virus load was very low, one of the tests picks up 60% of it, and one of the tests only 20%. When the viral load gets higher, they all do very well. So it means that these tests will not be very good if the viral load is low. Next slide. So what's the best test that we could do? The ideal home rapid test would have high sensitivity. That's important because about 40% of patients who are COVID-19 positive are totally asymptomatic. So it has to be sensitive for those people. Self-administered, so it's easy to do. It responds to the variants that we're all dealing with, and it's very stable. So, you know, it can just sit around in the room. Next slide. So another thing that happens is when you're doing these tests, it turns out that if you've been carefully trained, you're more likely to get the test to be positive. You see here with lab scientists or healthcare workers, it's 70 to 80%. And in people in the public, it's about 50%. So that even when you have a good test, if the person isn't well trained, they may miss some. Next slide. So I went over, and there have been 63 publications of various rapid tests, 63 of them. And I went through all of them and looked at them in terms of their sensitivity. The higher the sensitivity, the better the test. And you can see that, 20% of them or so were really pretty sensitive, 30% less so, and 20% are really nearly insensitive. And so I just averaged them so we get a sense of it. And it turns out that the rapid tests as a group are about 75%, 77% sensitive. Means they miss 25% of any infection. And they turn positive at various times. Some of them turned positive within 3 days of infection, and some of them it took 33 days before they turned positive. So you can see the rapid test could be a problem. That's why do these rapid tests. They say you should do it on 3 separate days. The idea is that this is being done very early. And if you hit it 3 separate days, you're likely to get one of the days when the viral load is increasing. But if you are asymptomatic and it's been a week or 10 days, then this test is going to be not very good. Next slide. And it turns out, and this is a test where they looked at that, where they looked at sensitivity, that is, ability to be correct, in patients who were known not to have COVID. And it was very good, 97%. But look at the one where it says sensitivity without symptoms. And that's the one we're most concerned with. And it was only 58%. So what they did is they did a very fancy computer kind of modeling and looked at it if there were 1 million people, and they assumed 10% positivity, which is probably a little low, but it meant that it was only about 80% sensitive, which means that the rapid test misses somewhere between 20 and 25%. And if you're asymptomatic, it misses 40%. Next slide. So looking at this, the rapid tests, the ones that are 15 minutes, I put 1 to 2 hours, but that's not true, 15 minutes, have about a 25% false negative rate. Even when you do it 3 times on 3 days, unless your viral load is increasing, you're going to continue to miss. The PCR is still very good. And I think saliva tests will do the same thing. So the rapid tests, while we're hearing a lot saying, oh, you should do it in everybody, and et cetera, et cetera. And in fact, they'll be cheaper. They're all going to be about between $10 and $40, whereas the PCR will be more like $50, $60. By the time you do 3 of them, of course, it ends up being the same cost. And it just isn't there yet. I hope it will be, but it's just not ready for prime time, in my view. Next slide. What happens if I get COVID-19? What should I do about my scleroderma meds? Next slide. So here's an examination of whether or not using the meds actually made any difference. So this was a group of patients with quote unquote connective tissue disease, probably mostly RA. And what you see is whether or not they were treated with biologic made no difference in death, but they were admitted to the hospital more frequently. So it looks as if background meds don't automatically mean there's a problem in getting sicker. Next slide. This looked at 600 cases over 40 countries. And what they found was, in terms of mortality, none of these drugs, except prednisone, resulted in increased mortality. So it looked here as if stopping the medicines did not make for worse, did not make for worse results. Next slide. Here, you see another 600 patient study, which there was a 9% death rate. They looked at the kinds of things that predicted mortality. I think the important things on the right. First of all, it looked as if taking the drugs decreased mortality, while using prednisone increased mortality. And then it's the same as we said before. If you have complicating illnesses, lung disease, diabetes, hypertension, all of those things make it harder on patients. Next slide. Well, the ACR did put something together to look at that. Now, I think what's very important about this is this was all based on extremely low quality of evidence. I've been on some of these. And what happens is we get a bunch of experts together. I've characterized them as old white guys sitting around a table. And we don't actually drink beer, but we drink coffee. And we try and come up with some reasonable recommendations. But the recommendations aren't based necessarily on good data. It makes sense, but we're going to have to use good clinical judgment. Basically, what it says is in the middle panels, if you've had some exposure, but you don't think there's much going on in terms of you getting ill, they suggest stop, and I wasn't part of this one, by the way. They suggest stopping many of the medicines that we normally do. And we'll get to when to restart them in a minute. But if you had known exposures, basically you should stop everything. They suggest something about non-steroidals like Aleve and so on. But in fact, I looked at the data and it's only applicable in very severe lung problems. And even there, it doesn't make much sense. So what they suggest basically is you stop everything when you have COVID. Okay? Not prednisone, you'll see, but everything. So it's important to figure out what to do next. When do you restart? Basically, you restart 1 to 2 weeks after your symptoms have resolved. And it varies a little whether you've had severe disease or not. And obviously, the more severe the disease, more careful you have to be. You have to work with your doctor to figure this one out. But generally speaking, you start again 1 to 2 weeks after the symptoms resolve. Now, what about those long COVID ones? Those symptoms that go on and on. And some of them, by the way, now 15% in one study were still there at 8 months. And the things that, by the way, in that case were mostly there were tiredness, loss of taste, loss of smell, and shortness of breath. But assuming that all the other symptoms go away, and these really are symptoms that relate probably to the body's reaction and no longer reflect active disease, then once you're into that more chronic phase, it's still 1 to 2 weeks, even though you still have some symptoms. Next slide. What about corticosteroids? This is about 600 patients with inflammatory bowel disease. What they found was if the prednisone is greater than or equal to 10 milligrams a day, it increased the probability of severe disease and increased the probability of hospitalization. did not increase the probability of death. So what do you do if you're on steroids? You can't really stop them. You just try and get them to as low a dose as you can and deal with it. It is not something you would use, assuming it should be high, to treat the COVID. Next slide. So, should I stop my scleroderma meds if I get COVID-19? In general, yes, while symptomatic and maybe 1 to 2 weeks after. And use common sense. We'll learn much more about this as research continues. But right now, these are just logical as opposed to evidence-based. Next slide. What about vaccination per se? Next slide. First question that some people ask is, can I get COVID-19 from any of the vaccines? Next slide. Well, if it's one of those little bits of RNA or DNA that you saw at the beginning, obviously you cannot reproduce the virus, and so you can't get the disease. And if you're looking at the viral spike protein, that's the rapid tests, things of that sort, or tests that are vaccines against the spike protein, again, and so you can't get the disease from it. What about those, like the older ones, like flu and so on, where they took the virus and they killed it? Well, they kill it with things like formaldehyde, things of that sort. There's no chance, none, zero, nada, that you'll have virus in the vaccine. So that there really is no worry about getting COVID-19 from the vaccines, no matter what you've heard. Next slide. What about which one's better than the others? Next slide. This is a listing of the number of vaccines that are being developed, and it was 127 at one point. And phase 1 is the early studies. Phase 1, 2 are when they figure out the dosing. Phase 3 is the big studies that we're all used to. And at the time this came out, there were only 2 licensed. There have now been 3 licensed, and there shortly will be 4 licensed. So there are a lot of them around, and there'll be a lot more coming in. I think it's pretty clear, 1, no live attenuated vaccine is going to make it. If by some crazy chance it does, keep away from it. Inactivated vaccines and all these others may be possible, but I don't think many of them are going to get through. The point being, there are a huge number being developed. Next slide. This is the Pfizer one. No, yes, it was the Pfizer one. First of all, you can see the percent of adverse events: fatigue, headache, chills, diarrhea, muscle pain, joint pain. All of these occurred, and slightly more commonly than the placebo, in the range of 2 to 3 times as common. I think one thing that was very important is that after the first dose, the efficacy was only about 50%. That kind of is reflective in the Johnson & Johnson, where the efficacy is in the range of 70%, not the very high one. But when the Pfizer one was done with 2 doses, as you know, it was 95% effective. And the reasoning here is the first dose primes the body, and the second dose makes it active in the memory cells that keep the body protected long term. Next slide. Even there are a whole bunch of differences. You can see here 4 different vaccines. And you can see that depending on the time from the first positive test by PCR, you can have either very low sensitivity or pretty high sensitivity. By the time about a month after infection occurs, sensitivity is pretty good. But remember, even there, look at the sensitivity, 75%, not 100%. And it also changes by age. You can see that on the right, where people who are older have less of an immediate response, although eventually, usually by 2 months instead of 1 month, they too have pretty good sensitivity. Okay? But it's still only 75%. So the antibody tests vary among measures, and they also vary among how good they are. And this is the same you see here. Next slide. This one is out of place. Next slide. So, next slide. What are the differences among the vaccines? Well, the AstraZeneca one is about 85% sensitive. The J&J is about 66, 70%. The Moderna and the Pfizer, 90 to 95%. So there are some differences. Now you'll hear people say, oh, no, it's not a problem. They're just good. Well, the fact is, all of them are significantly better than nothing. But there are differences here. Furthermore, the Moderna has been shown to cover at least 3 of the 4 variants. I'm going to make the assumption that Pfizer does the same when they test it, but we don't know that for sure. For the J&J, the variants are slightly less effective by about 9 or 10%. We have no data on AstraZeneca. Now, AstraZeneca has had another problem. Initially, the study was put on hold because there was some pulmonary emboli and clots to the lungs. And then they were examined carefully, and it looked like there was no difference between patients who got the vaccine and the control population. There's a bit of an issue, however, because just recently, the specific cases that had the clots were published. And they were in young people without previous, most of them, young people or relatively young people without previous issues that would predispose them. And there was a pretty good rationale for it, where some of the aspects of the vaccine could cause antibodies which reacted to platelets, et cetera. It was, anyway, there was a good physiological reason for it. So although there have been statements made that there's no issue here, I think that we have to be just a little bit careful about this possibility. Now, look, it's very rare. We're talking 1 in 500,000 people. But compared to the others where we haven't heard this, that may be a difference. So if you ask me about differences, I'd say that the Moderna and Pfizer was best. The J&J was the next one to use, and I'd be a little bit careful for now about the AstraZeneca one. Next slide. But there's something that's really fantastic, and these are nanopart particles. What happens is these tiny little particles, nanoparticles, a billionth of a meter, can be made so that they have little tags on them. So you could put multiple different antigens, multiple different bits of viruses on the same one. So for example, the one that's called Mosaic 8, could have 8 different vaccinations with one shot. This isn't there yet, but I think this is incredible and maybe a way forward. So when you go and get a vaccine, you get a vaccine for everything and you're done. Pretty cool if it happens. Next slide. What about if you do get vaccinated, how long would you be protected? Next slide. What you can see here is the immunity duration. And you can see here the IgG and IgM, green and yellow, are lasting well beyond the end of the study. Next slide. And what we saw before was that the antibody hung around for about 6 months. Next slide. And there was a study which showed that patients who had COVID-19, how many of them got it again, indicating that they wouldn't be, they wouldn't have antibodies anymore. And it was 0.7% at a rate of 0.3 per patient year. 0.3% per patient year. So it's really going to be very uncommon. So if you have the antibodies, you got a less than 1% chance of getting reinfected. Next slide. So the protection is at least 6 months, maybe longer, but my guess is that we're going to have boosters, just like we do with any other virus. Next slide. So how safe is it? Both short and long term. Remember, that's one of the very real concerns of everybody who gets this. Next slide. One of the reasons that people worried about it is because these things got out so quickly. So how was that done? Well, if you look at the bottom or the top, you see in the top, everything is sequential. First the orange, then the yellow, then the blue. Those are different phases. But if you look at the bottom, they overlap tremendously. And then if you look at the top, manufacture started after approval. But here, the manufacturer, they took a chance and started before approval at the time of the end of the phase 3. And those things are what made it so much faster. Of course, the FDA also helped. Next slide. So what about side effects? But first of all, the manufacturer, not something we need to worry about. I think it was a major step. But if you look at here, what you see is the Moderna is orange, the Pfizer is blue, and the Moderna has more, whether it's joint pain or chills or muscle pains, headaches, etc. And these are percentages. So patients really, some of them get it very frequently. Of course, pain is like most people get. But fatigue happened in about, 70% of patients, etc. So it's very frequent, and Moderna has it a little bit more. It's not statistical, but it's a little bit more. Next slide. Now, there are long-term side effects. This looked at long-term side effects, which started about 1 month out. And you can see that among 200 patients in 46 centers, half of them very critically ill, there could be encephalitis, strokes, progressive neurological deficits, it's called Guillain-Barré, which goes away, seizures, loss of consciousness, a kind of meningitis, not infective, and then a bunch of other things you can see there, hiccups and loss of taste and paraparesis and all sorts of other things. So how does this compare to other flus? In the 1976 flu vaccine, they had some Guillain-Barré, but when they compared it The actual flu occurred, the Guillain-Barré occurred 17 times as many times when they had the flu as when they had the vaccine. So the vaccine was actually preventing the Guillain-Barré, even though it did occur just as it's occurring here. And then there was one flu vaccine in 2009. One manufacturing lot was defective, and they had neurological problems in 1 in 55,000 patients. Nowhere else did they have it, but nevertheless, there it was. So, in fact, there can be some longer-term neurological effects. And we talked about it already, that 15% of patients have some symptoms that last even more than half a year. So there are rare side effects, some of them severe, but very rare, probably less rare than from the disease itself. Next slide. All right. So what I just said was that side effects occur. They can be long-lasting, but are very infrequent. We now know that we've now followed patients out to 8 months, so we have a little longer follow-up. That severe side effects can occur, but occur at a rate that probably is less than the underlying disease. So now, if you had COVID-19, do you need vaccination? Next slide. If you look at this looked at patients who are infected, and you can see the bottom is 4 different variants. One of them is the European one, the UK one. One of them is the South African one, and one of them is the Brazilian one. And you can see that the percent of patients that had neutralizing antibodies in infected patients was where it is there, pretty low. And it didn't go up in convalescent patients. You can see that there. But the patients who were vaccinated, even after they had the COVID-19, they produced a much higher percent of all of the variants. In other words, if you have COVID-19 in this case and you get vaccinated, it protects you against the variants. Next slide. This says basically the same thing, so I won't spend much time. But the point being here that compared to the uninfected individuals who were vaccinated, those who had infections and were vaccinated had even higher response than the uninfected vaccinated group. You can see that on the right compared to the left, higher numbers. Next slide. How quickly does it occur? In this slide, what you see is the unvaccinated in the lowest number. Then once you got the first shot, you see how fast it goes up. And then when you had the second shot, it didn't go up much more. The point being that what seems to occur is when you have your first vaccination shot, after you've had COVID-19, you get a great response, and the second shot doesn't gain you much. That doesn't mean you shouldn't get the second shot because you can't get away with it. You're going to have to get both of them. But in the long run, the people who have been previously infected may only need one shot, kind of the booster shot. Next slide. So if you had COVID-19, should you get vaccinated? Definite yes. Next slide. Can it cause my disease to flare? Next slide. What you look at here is we don't have the data, in fact, on COVID-19, but we have some data on zoster vaccinations. And what you can see is there was no flare, whether or not people were on background medications, except with steroids, where there was a flare if you've had the vaccine. So steroids associated with flare after vaccination, none of the other drugs. Next slide. Now, there have been some data in some autoimmune diseases, nothing in scleroderma yet. But this looked at a poliomyelitis vaccine campaign in SLE patients. And what they found was that in this vaccine, 5% of the lupus patients had a flare. So it can occur, although it's very uncommon. Next slide. So the answer to that is, yeah, or very uncommonly. I think there's a whole lot we don't know, obviously. But I think that if a patient has a stable disease, they probably won't flare. If the disease is unstable, you're going to have to be pretty careful. And you and your doctor will have to discuss whether or not to get the vaccine. Because if you have unstable disease and you flare, which might make it a lot worse, you got to be careful. What's my approach? I really talk it over with the patient. We decide what the danger of the flare is and compare the two. If getting the vaccine would put you in true danger, not a thing to do. On the other hand, if the flare of the disease is so bad that if you get the disease, you really can get super sick, you may have to take somewhat of a chance. It's a tricky question. Next slide. Will it work? Will the vaccine work if you're immunosuppressed? Next slide. Here's some data, not with COVID, but with other vaccinations. This is a flu vaccine. And you can see, you look at the green because that's the one, you look at the blue. And you can see that in patients who are not on any medications, nearly 100% of them are protected. Hydroxychloroquine, pretty close to the same. Prednisone, probably 10% less. For azathioprine, for some reason in this study, it was much lower, but that hasn't been shown in others. Next slide. So with azathioprine, you really might see an effect, but generally speaking, about a 10% decrease in the effect. Next slide. Here, looking at tocilizumab, Actemra, the one that some of you are using, it looked like the protective antibodies were about 76% to the flu virus. In normals, it's about 85 to 90%. So once more, about a 10% decrease in efficacy. Next slide. Okay, next slide. Here, looking at flu vaccine after a TNF inhibitor, infliximab. And what you see, next slide, is about a 10% decrease. The light yellow is just a little lower than the controls, which are RA controls, and they themselves may be lower. So once more, about a 10% decrease. Next slide. So yes, the vaccine will work if you're on an immunosuppressive, but it might be 10, 15% less effective, going from 90 to 95 to 80%, for example, for Moderna or Pfizer. Next slide. And do I need to stop my meds when I'm being vaccinated? Next slide. Well, that relates to all of the cells in the immune system that you see here. Next slide. And there has been some guidelines by the American College of Rheumatology. And they got very complex looking, but the bottom line here is that you depend on the site, on the duration in which some of these medications stay in the blood and the tissues. So, for example, methotrexate tends to stick around some time. And so they say, hold it 1 week after each dose. For the JAK, likewise, 1 week after each dose. For the abatacept, because it hangs around longer in the tissues, 1 week before and 1 week after, etc. Next slide. Go back if you would. I skipped through some of these. I want to make sure you understand. Generally speaking, if you're going to get the vaccine, what you do is if you try and make sure the drug isn't hanging around in your blood. So methotrexate hangs around in the tissues. So you stop for a little bit, for a week, to make sure the body can mount a response. For the JAKs, the same. For abatacept, which hangs around a little longer, you got to stop a little before and 1 week after. Okay. Now they say you don't have to do it after this, you have to do it only after the first dose. But in fact, you probably ought to do it after each dose, which means overall, you may only get 1 or 2 doses in over about a 6-week period. For cyclophosphamide or for rituximab, it's a little bit more complicated. If you're giving it IV, you probably have to give the dose 2 weeks before the next IV dose. And for rituximab, you want to give your dose of vaccine 1 month or so before the next dose, and maybe even hold the dose for a month because that hangs around a long time. Next slide. So what we've done is we've answered a bunch of questions. Whether or not you should get the vaccine, and there's some good issues. Whether you should use a rapid home test. And I would suggest that it really doesn't make a whole lot of sense to do that yet. What about holding the scleroderma meds if you get COVID-19? Yes. And then restart 1 to 2 weeks later. Next slide. Can you get COVID-19 from the vaccines? Definitively no. There are a bunch of vaccines. Which one's better? In my view, Moderna and Pfizer are better than J&J, although there's some argument about that, and that both, because of the potential side effects, are better than the AstraZeneca. How long will you be protected? At least 6 months, may well be for longer. How safe is it? Well, actually, it's pretty safe. You're going to get a lot of mild short-term side effects for which you can use Advil or Tylenol, by the way, no matter what they tell you. And then for the long term, they're very, very rare, but need to be considered. Next slide. Do you need vaccination if you've had COVID-19? I think you really do. Can it cause disease to flare? Yeah, I think it can, but rarely. About less than 5% of the time, probably. Will it work if you're immunosuppressed? Yeah, very likely. But as noted, it might be worthwhile to stop the medicine during the time that you're getting the vaccination. Okay, next slide. Before we leave, I know you want to raise your hand. So all those who believe in psychokinesis, raise my hand. Oh, it's going up. Oh, no. I'm kidding, of course. Next slide. Thank you for your attention, and let's go and have some questions.
Thank you, Dr. Furst. That was great. And you answered a lot of questions. I was trying to keep up with questions that I already have because I have a lot and what you're answering. And I really appreciate that. So I'm going to try to weed through some of them. And if I end up repeating it and you've already answered it in your slides, would you just tell me, Tina, we've already discussed that?
Well, what I'm going to do, what I'm going to do is I'll just answer them very shortly. Okay.
That sounds good. I'm going to start with the ones that sent them to me in the beginning. And one was specifically from somebody who had a transplant in scleroderma, and he sent you a link to some information, and I sent it to you regarding the vaccine, and I think the way that it, why can't I think of the right word?
Well, let me just do a quick stab at this, okay?
Yeah, the antibodies. That's what it
right. The fact is that once you've had a transplant, you're going to be immunosuppressed for a long time, and your body isn't going to respond normally. And you really probably oughtn't to get vaccinated for at least a year after the transplant. And I think that's a very short answer to a very complex question.
Okay, that helps because he's had it much longer, the transplant, than a year.
Then he's good.
Okay, good to know.
Oh, by the way, someone asked whether I'd been vaccinated. The answer is absolutely. I got tired for about a week afterwards. My wife got a little bit sore, and that's all. But ain't no question about my getting vaccinated.
Good. Glad that you said that. Thank you. Would you advise that people who have mast cell activation problems with allergies should take any of these vaccines?
That's a very difficult question. It's the same question as if I am allergic to other vaccines, should I be vaccinated? And I think this is one that you better talk to your allergist about, because you may, if it's absolutely necessary, you may have to have some sort of treatment beforehand. And if there's any question, probably it's better not to get vaccinated just yet, but wait till population immunity occurs and you'll be a little safer.
Well said. Thank you. You did already very clearly talk about if it would trigger autoimmune disease flare-up. So I don't think you need to go over that again. Do you agree?
Correct. Right.
Would patients on blood thinners like Eliquis need to hold their medication prior to and after their COVID vaccine?
I really don't believe so. You might get a bruise, but it's not going to be dangerous to you.
Okay. I think you already answered this pretty clearly. What are your thoughts on severely compromised patients and the safety of the vaccine, long-term safety of stable patients?
Yeah, we've talked about that.
Okay. You already talked about your opinion of the different shots. I think any long-term effects. I think you already answered this very well. Do you think there are any long-term effects of the vaccine in your experience? You have outlined that pretty good. Do you agree?
Yeah, I think, the fact is we should not say there aren't any, but they're very, very uncommon. I'd say very rare. And that you have to balance the good against the bad. You never get something for nothing. And this is just true for this as well.
Thank you. Somebody's wanted to get your opinion on what they think might be side effects of the medicine. I am several weeks post second Moderna. I've been itching severely for the last 10 days. Seems slightly better. Thoughts?
Very likely due to that. Good old Benadryl or Zyrtec might help.
Okay. I think you also talked about this, but maybe you can elaborate again. How do you know you built up antibodies after both shots, especially if you are on immune lowering drugs like Cellcept?
Problem with the tests are that they're only 80% accurate or sensitive. And so you really can't tell. If you get the test and it happens to be positive, great. But if it's negative, you don't know whether you're positive or not.
Okay. Kind of going into the same direction with how do we know if we're protected after vaccination, after a couple months of, like this person had it in February, beginning and end, and is on immunosuppressants and they still double mask?
The fact of the matter is they're doing the right thing. Remember, even the 90 to 95% sensitive is that it's not 100%. So everyone could get it. There's a chance. And that's the reason continuing to mask and being a little bit more careful, less careful than we've been, perhaps. And that I shouldn't have said. But masking is just going to be the way we are for now, folks.
Thank you. Interesting. Are people with scleroderma more likely to get the illness? If they get it, will they become more likely to have greater damage?
The answer to that is they're not more likely to get it, but if they get it, they're more likely to get severe problems.
Yeah. I had no reaction to Pfizer shots. Does that in any way indicate my immune system did not respond as well?
Great question. The fact of the matter is the side effects reflect an effect, not a side effect. But the fact is also that 90 to 95% of people get responses. And what that means is your body didn't have to have a generalized response, but probably a very specific response. My response to that is good on you.
Good. I think you answered this, and this is in your slides. How long will the vaccine protect us? You were very clear on that. And are there studies that are looking at COVID and scleroderma? And you had that in your slides talking about scleroderma. So do you agree that we've covered that well?
We've covered it as well as we can. The fact of the matter is a good deal still needs to be done, but this is the data as of now.
Okay. And can you just reiterate once again, being that you gave an idea of how long it lasts, should people do antibody testing after the COVID vaccine or not?
I would suggest not. If you are truly among the worried well, and if you get it and it's positive, that probably means you got it. And you have that you have the antibodies and that you're okay. But if it's negative, you shouldn't go home and worry about it because it can be a false negative.
Okay. With people being vaccinated with autoimmune disease, does the vaccine cause rare blood disease or seizures? I think people are setting things on TikToks, and I've even seen a couple. My husband's even shown me some, and I think that people are really focusing on what they're seeing people talk about their side effects.
So I think the side effects are real thus far, very mild. Certainly no, I shouldn't say this. It's not as if you can't get any of these side effects, but so far they have not been documented. And when we look at other vaccines, we also don't see it. So the probability of, let's say you get an anemia suddenly, it's much more likely that it's due to something else or due to your, than it is to the vaccine. And it is not likely that just because you have scleroderma, you're going to get in serious trouble because of the vaccine.
Thank you. Interesting. Should we be concerned if after full vaccination of COVID antibody, after full vaccination, a COVID antibody test shows no antibodies?
As I said, the test isn't that good.
Okay.
No more need to be said.
Okay.
I did see a little comment about people who were on Cellcept or methotrexate or some of those when they got vaccinated. Should they assume that they didn't get appropriate vaccine response? The answer is, as I've said, it's about a 10%, 15% less effectiveness, but that's all. It's not as if you're not likely to get a response.
Thank you. I'm noticing people are putting messages in the chat. And as I mentioned in the beginning, could you please wait until we're done? Because I have about 45 questions here and we might end up going over them. And now you're going to make me weed through your questions and it's a little difficult for me. And we might be redundant in some of the questions. So please, if you could wait until we're done with what I have in front of me.
Or maybe, Tina, maybe at the end they could put their hands up like Lori is waiting, and that might, they could even not have to type it in the box.
Okay, and if for now, if you could put your hands down, and then when we're done, then put your hands back up, and then I'll go through you. That would make it a lot easier too. Okay, let's see, where am I now? You pretty much talked about this too. I've had both my first and second. I've noticed more symptoms than normal. Does or could the vaccine cause this and or add to flare-ups?
Very unlikely.
Okay. Please clarify the confusion over CDC's policy regarding flying. Is it safe to fly or not if you're vaccinated?
It's far safer to fly when you're vaccinated than you're not. Should you maintain all of the precautions? Yes. If you are a particularly frail individual, if you're on oxygen, if you're doing things of that sort, I would still wait. If you have an illness and you have some symptoms, and generally speaking, you're pretty good, then you can go if you're just careful. By the way, you shouldn't go international just yet because you might be flying into an area that's not yet controlled.
Thank you. I'm not sure exactly what they mean by this. What is the estimated time we can expect coverage from the Pfizer vaccine? Maybe they're saying when it actually starts working once they get it?
Now, my guess is that they're talking about how long it lasts. You heard a bit of statistic that after the first dose, you get about 50% protection. And after the second dose, you get about 90 to 95%. The ideal time to wait is that which was arbitrarily taken before, which is 3 to 4 weeks. But in the UK, they wait 12 weeks and it seems to be okay. So, you know, it depends a little bit on the process where you live, that you should wait about, if you can, 3 to 4 weeks, but longer is okay. The duration of effect, as far as we know thus far, is at least 6 months.
Thank you. What is the risk of exposure to unvaccinated persons if we have already had the 2 doses of Moderna?
10%, 5%, just like it says.
Okay. So we talked about flying. What about 3 things? Dining, inside, going to a movie theater, or an indoor gym?
Play it the same way as flying. Be reasonable. Try and not sit on top of each other. Well, that's a different issue. Sorry. But try and be careful. Use the mask. Try not to go there when you're sick. So in case you get sick, you won't get even sicker.
Okay, thank you. I'm having a non-vaccinated person flying here from out of state. Is it safe for me, I'm fully vaccinated, to have the non-vaccinated person as a house guest for a week? And is it safe for me to be in the car with the out-of-state non-vaccinated person?
That's a tricky one, folks. I'd be a little bit careful if I were you just yet.
Okay.
So I wouldn't say absolute no. I mean, for example, if this was your grandma who's 98 years old and you might not see her again, take a chance. But if it's a 40-year-old person, put it off.
Thank you.
But by the way, masks would be de rigueur in this case.
Thank you. The next one is safety of the mRNA nanotechnology in vaccines that have never been tested on humans prior to the pandemic. And when tested on animal studies prior to the pandemic, the animals reportedly got autoimmune conditions and or died. What are the speculated ramifications in 1, 10, 20, 30 years after receiving vaccines?
A good question. Answer is, who knows? So far, nanotechnology has been used quite safely in other monogenetic diseases and has been very effective. And the follow-up has only been 5 or 8 or 9 years, and it's been very good. I don't think we can say anything more than that.
Okay. I heard that before they give the COVID vaccine, they ask, are you allergic to polyethylene glycol? how would you know if you're allergic? I heard 70% of people are allergic to it, and that PEG has been linked to anaphylactic shock, severe reactions, and death. It has also been linked to other adverse reactions such as chronic skin rashes and other chronic inflammatory conditions.
So one thing you can say is if you get it, you have antifreeze on board. But lacking that, the fact of the matter is that PEG is in many, many different vaccines and has been used very safely. You can't be 100% sure, but if you've been vaccinated with several of the others, the likelihood is that you've had the PEG and that it hasn't given you any trouble. Remember, these things are attached to the payload, and they're there to make it your body not get rid of it so quickly, so your body has a chance to react. So that's what you want it to do. If you've been vaccinated in other ways and not had a problem, I wouldn't get too upset.
Thank you. Before I go too deep into this one, are you familiar with this CRISPR? Looks like
yes.
study.
Let me answer that quickly. Otherwise, it goes on much longer than it should. The CRISPR technology is an excellent technology. It is made for huge advances in medications and pharmaceuticals. The CRISPR technology is simply a way of being very, very specific in production and measurement. I think the question basically asked, is there a problem with it? The answer is the CRISPR technology is not in any way transferred to the person. It's just used as a way to make something else, which is then applied and used.
They mentioned what are the short-term and long-term consequences when one's DNA is permanently or changed by this technology, nanotechnology.
Well, you have to be very careful. In sickle cell disease, it's being used long-term and is totally safe thus far being 8 or 10 years. You can't say for sure. There's always a theoretical possibility, and you always have to balance the likelihood of good response to the side effect. And you know, medicine is partly an art. And so you can't get absolute certainty. You'll never get absolute certainty.
Well said. You talked a lot about the different vaccines, and you did talk a little bit about this AstraZeneca, so it kind of goes with it. But the specific question was that they're seeing that it's been banned in places like Germany, France, Italy, and Spain because of blood clots and death. What is the mechanism of injury that causes the blood clots?
So it has to do with, it is thought based on about, I think it's 6 people with an interaction between part of the antibody and a response of the platelets in the patient's, in the patient's, mostly the bone marrow, so that you end up with increased clotting from that interaction. And it's the reason I'm suggesting we need to be a little bit more careful than the EMA has been.
Because then it follows with this information, would the other vaccines hold true to the potential adverse reactions of these blood clots also, or death?
So among other things, these are very different vaccines made by different technologies. And thus far, we have not seen it. And we probably would have seen it because people are now looking. And we've had, I forget, 1/4 of our population has now been vaccinated. We're talking 90 million people, for goodness sake. Yeah. We'd probably see something. I don't think we're going to.
Thank you. I heard if you get the flu shot, it increases your risk of getting COVID infection by 30% because the flu vaccine utilizes serum from other animals, such as chickens that naturally have coronaviruses.
That's pure urban myth. There's simply no truth to it.
Thank you. I don't know if you have time for this. What are your thoughts on the virologist, Dr. Vanden Bosch? And it's a 13-page letter to WHO.
Yes. Okay. So this is a person. Yeah, this is a person who said that you must not vaccinate in the middle of a pandemic. It is an opinion. He's allowed to have his opinion. That's what scientists do. We argue about various opinions.
Thank you. Please comment on the role of ivermectin for prophylaxis treatment and post-COVID syndrome, long hauler syndrome, ?
Good question. I think a better approach seems to be actually taking these folks and revaccinating them. It seems in the case of just case reports that those individuals, when they've been vaccinated again, clear up rapidly. If we're going to do something, we need to do a study of this rather than just give it to people. But this looks like one possible way forward.
So with that said, do you think that ivermectin is going to start being more concentrated on, looked at, studied?
I'm sure it will be looked at some more.
Okay.
I'm not sure how many people are still hanging in there, but I hope this isn't getting too long for people. I don't mind, but.
Well, so far there's 59 still here and we were at 66 and I don't think it's a problem. And people can, if they feel, if it is too much, by all means, remember we're recording this and we will be more than happy to share it as we always do with all of you once we have our edits finished. And you can watch it in its entirety. You can pause things, you can take your notes. So, but I think most people want to hear this and are gonna hang in there, Dr. Furst.
Okay.
Thank you for saying that, because I forget. Let's see. You kind of talked about this. What are your thoughts on COVID vaccines? I don't know if it was for babies and teenagers. Do they really need it? The CDC reported that less than 19 years old is 99.998% chance that they will survive a COVID infection.
So I think it's a good issue. I think it's being tested at 12 years and older. I think there's even one study from 2 years and older. I think it's a possibility. I think that when the testing for antibodies become sufficient and good enough, that would be a way forward. But right now, it's like saying, you know, just because measles isn't going to kill you, except when it kills you, it don't need to be given the measles vaccine.
Thank you. Let's see. I've been vaccinated as well as my son and wife. When will it be safe to fly to visit them and or grandkids ages 3 and 6?
We've kind of covered that. I think that good common sense should prevail, and care and masking and so on. And if it's important enough to you, then you should do that, making sure her parents or their parents are well protected as well.
Thank you. I don't know if you specifically covered somebody that has anaphylactic reactions to food or grasses, which would be the safest vaccine, if you have a history of that?
The safest vaccine is be damn careful. I think grasses and so on, unlikely, but I really would recommend that you talk to your allergist before you go ahead.
Thank you. I'm not yet diagnosed. I have many clinical indicators that I have scleroderma, and I'll be seeing a specialist in August, which probably is the earliest they can get in.
Tina, let me answer that. The question is a patient who's afraid they have scleroderma, and what exactly should she do?
Because she wants to hold off on taking immunosuppressants if necessary, I guess.
Well, first of all, there's a many steps before that. If she can find someone who can see her or him earlier, that would be the best way forward. But if you can't, and all you have is suspicion, I would suggest that the vaccine is more important to you than the diagnosis right this second, unless you are really sick.
Yeah, because she did say that in some ways she's, doing things to keep herself proactive to reduce inflammation and other things. She sounds like she's been doing a lot of her homework. But as you know, it's hard sometimes to get in to see you guys, and she's not here. She's out of state. And so we know that it's important she sees someone, because we know 90% of the time the other doctors don't know how to give them that specific diagnosis. This is probably why they haven't, because they don't know. So she just wanted to make sure. And I think you've answered it. She was more worried. I'm much more worried about scleroderma than COVID at this point. She just wanted to see if you thought it was a wise decision, which one. And it sounds like you've answered that.
Yes, I think she should get, unless she's sick, if she feels ill, short of breath, etc., then she should get the vaccine.
Thank you. Let's see. I think we actually got through them.
Great.
Yeah, we did.
So now there are people who are waiting.
Yes, I've got a couple in the chat box, and let me see. I don't know if they're redundant questions at this point or not. Even though you talked about airline, is there a specific test that you need to travel on an airline?
No, not that I know of. I wouldn't be surprised if sometime they'll want certification of vaccination, but not yet.
Okay. You already answered this, and she said, never mind. And yeah, have you been vaccinated? You answered. After you've been vaccinated and you are immunosuppressed and on CellCept, should you get tested to see if you have built antibodies? If not, I think you answered this. Should you get another type of shot?
No.
Okay. I have pulmonary fibrosis as a result of pneumonias, but it is not progressing and I am not on any medication for it. So my question, since COVID affects the respiratory system, does contracting COVID increase the chance of activating the progression of pulmonary fibrosis that is currently not progressing?
The answer is very, very unlikely, but if she gets COVID, she could get a lot sicker. So she's one of those individuals who I really think requires vaccination.
So some people are learning about what your thoughts were about stopping some of their meds, but already got the shot. And this one says, what if you didn't stop the methotrexate or CellCept when getting the vaccine doses? Will the protection be less?
We kind of have covered that. It will be 10 to 15% less, but you still need it.
I'm not sure if my question has been answered. And that's another thing. Some of you might have sent things to me when we already started the meeting. And if it was really late, I was not able to copy your questions.
Tina, I'd like to ask you something for me. A lot of these patients have been sitting, waiting with their hands up. Let's deal with those and not deal with the chat box right now.
Well, I think I'm almost done. So let me at least ask this one first, because this was before the hands went up. Is there any data on the vaccine and its connection to ITP thrombocytopenia?
Yes. In fact, the vaccine has been, in very rare occasions, been associated with thrombocytopenia. They're basically case reports. We don't have any controls for it, but is a tiny possible thing that we should consider.
Thank you. I'm going to go with the first hand up, and you can unmute. And when you're done with your question, to put your mute back on. And Lori Hainsley.
Hi, Dr. Furst. I would like to express my heartfelt appreciation, affection, and love for you and Elaine for all of the things that you have done for us. I'm going to cry because I really feel
Well, thank you.
You have always been here for us, for our support, and for our knowledge. And for those of us who like the information, it has decreased our anxiety and has improved my life in so many ways just to have you here. So I just wanted to tell you that.
Thank you.
It's just been so great to have you.
Aww.
Thank you so much.
How sweet. Thank you, Lori.
And Elaine thanks you as well. She's up here.
Hi, Elaine.
We miss you, Lori. By the way, you can always come back to San Diego.
Thank you.
Okay, Cheryl Bishop.
Hi, Dr. Furst. Thank you for all your good information. I'm sure you're not going to be surprised with this question, but can I watch Carlo now? And can I be in a room if everybody's vaccinated? If we're all vaccinated, do we still have to wear a mask in the car? And do we all have to still be vaccinated?
If you're all vaccinated, the recommendation is that you don't need to wear a mask.
Thank you. And my grandson? I'm dying without him.
I think that a mask will be necessary.
Okay. Okay.
Thank you.
I can see him now more. Thank you.
Right.
Okay. Amy?
Hi. Yeah. I was wondering if you can talk about this T cell test. And I don't know if that's only relevant for people who got the Johnson & Johnson vaccination, but I'm in that category of people who's on CellCept, and I got the antibody test that you recommend I don't get, and I didn't have any antibodies. So I don't know if I need to take this T cell test.
Are you talking about the T-spot? Is that the test you're talking about?
I don't know that that's what it's called. I just know that, so I got the Pfizer vaccine, and then I was taking my CellCept all along. I took this antibody test, have no antibodies. And so then I heard something about a T cell test to see if you...
Remember that just because your antibodies are negative doesn't mean you don't have antibodies.
Right.
Remember that you got a 20% chance of it being wrong. The T cell test basically looks at whether there are active T cells aimed at COVID-19. It is not an approved test. I understand the reasoning. I can't tell you how good it is.
Okay. Thank you.
I think you should expect that you are covered.
Okay.
And Jackie, I see that you just got here, and she's out of state and didn't realize the time difference on it. Yes, it's recorded, and yes, he answered your question, and it will be, when you watch it, you'll get all your answers, okay? So I'll definitely make sure that when we do our edits, you get a copy of it. Let's see, Lucy.
Dr. Furst, this is Lucy from Phoenix. I'm going to your neck of the woods April 28th. Okay, my mom, she's almost 90. She got her Johnson like 2 days ago. And my big sister got hers Johnson 2 days ago too. My adult brother has nothing. Do I have to wear a mask, or somebody have to wear a mask if my brother's not vaccinated?
Yes.
Okay. And he does too?
Yes.
Inside the house?
In this case, you've got to remember that the Johnson is only about 70% effective.
Okay. Okay.
So I hate to ask you to do it, but I think that's a safe way.
Okay. Thank you very much.
Sorry.
No problem.
Let's see. I think I don't see any more hands. I just went through the...
Tina, there's some on the bottom of my screen. Wanda can go.
Okay. Yeah, great.
Hello. Oh, hello. Am I unmuted?
Yep.
Okay. As a healthcare professional, I do work at a hospital, and this is just what I see the hospitalists do and other hospitalists do for what it's worth in terms of the immunosuppressant, like with steroids. But during the inflammatory cytokine storm phase, that's when the hospitalists use the corticosteroids. But during the initial phase of the viral replication, which lasts 8 to 10 days, that's when they were using those, other therapies, and some were using ivermectin, but with the monoclonal antibodies and, things like that. That's the initial phase of the COVID disease. And then the second phase is the inflammatory stage, where they use the corticosteroids and oxygen. And then the third phase is the phase of thrombosis, where they use the blood thinners, the heparin, and things like that. So I don't know what it's worth in terms of, because I'm not on immunosuppressants. But I don't know how that would relate to, because I know there's a lot of question about, should I stop my immunosuppressants, or should I continue them? When should I continue, or whatever? And I know you had touched upon that, but I'm just wanting to share that this is what they do in the hospital.
Thank you for doing that. I think we have to be very careful that everyone realizes that these are hospitalized patients. They're not patients like yourselves who are outpatients, a very different situation. So I appreciate your going through it.
I think Melanie was first, and then Roxana.
And Roxana, we did answer your question, and it is part of our recording. I see your message you also typed in about mast cells.
Yes, thank you. No, the question that I'm raising my hand about is different.
Okay.
Thank you.
All right, let's let Melanie go, and then we'll let Roxana.
Mine is pretty simple. From the information that we got today, I learned that, the vaccinations only can supply you with maybe 6 months of protection. If it does come when they say we have to redose, like if it's like a flu shot every year or something like that, would you recommend the same brand of shot, or does it matter what vaccine you get?
Great question. First, we've said 6 months is what we expect. If we're lucky and we get good studies, it may be longer. There are studies presently being undertaken where they mix and match. Until those come out, I would recommend staying with the same one.
Okay. And I guess, Roxana, you can go ahead now.
Yes, thank you. I was just going to ask if the doctor has heard of a vaccine coming out called Novavax, because that's the one my doctor has been telling me to wait for.
Yeah, Novavax is coming out, obviously. I don't know what stage it's in because I haven't seen it here, but understanding it, it's about the same as the in terms of efficacy as the Moderna and the Pfizer. I'm not quite sure why your doctor thinks it's better, but I'm not aware of any significant differences. Still, if you and he want to do that, that's fine.
Okay, he seemed to say that it was had less of a genetic modification variation to, I don't know, to it. But I think he's mistaken, because I've been reading articles about it using nanoparticles and that they take a moth virus cells and they do alter them.
Yep. I think that one of the other questions kind of touched on that.
Oh.
And it's a good question that you put forward. I think what we need to do is work with your doctor on this one. And I'll tell you what I'm going to do. I'm going to go look this up afterwards because I can always learn something.
Yes, thank you.
Wonderful. I always appreciate that, Dr. Furst. I got a question in the chat box. I know that doctors are hopeful that the work done on the vaccine will help treat cancer. Could it also be applied to scleroderma research since collagen is a protein?
The answer is absolutely. I think the technology that's being developed here is going to change a lot of how we approach medicine in the future. I know it's an awful thing, but the silver lining here is remarkable. The technology advances are going to be truly life-changing for people.
Thank you. Michael.
Yes, Dr. Furst, I have a question regarding the immunization. In how far does a vaccination influence the course of a COVID-19 disease? Let's say if you are vaccinated, but you get infected anyway, does the vaccination reduce the risk of a severe outcome?
So far as we know, the answer is yes. As you heard, the incidence of this is a mere 0.17% recurrence. So we don't have a lot of patients on this, but the answer is in those patients who have recurrence, they've been mild to moderate disease.
Okay. Thank you.
Good question.
James asked, in UK, been told that to mix vaccine is okay. I'm likely to get a different one. It's a concern. Can we get authorization from a doctor to say we can get the same vaccine twice?
Yeah, as a matter of fact, the answer is we don't know. And so I think we should be a little bit careful. And so I believe that you should try and get your doctor to give you the same one. If there are data out there, I would love to see it. Just so everybody knows, there have been over 55,000 articles on COVID thus far.
Wow.
Point being, no one can keep up with all of it.
Thank you. Carl, were you raising your hand? Can you unmute?
Yes, my question was similar to Michael's, but a little bit different. So if we've been vaccinated and we still manage to get COVID, do we have it for a shorter period of time, and are we less likely to be contagious to other people than somebody who's never been vaccinated?
Obviously, we don't have those actual data, but my assumption, in fact, is that you will be just as infective, but probably for a shorter time, because it's likely that your antibody response will be pretty vigorous. So this is pure speculation. I think it's going to be milder and shorter in terms of infectivity. I can't tell you in terms of symptom duration. I don't know that.
Okay, and in terms of being contagious to others?
As I say, I hope it will be shorter because your T cells should be active and responding quickly.
Thank you.
I don't see any more hands, guys, and I don't see any more in the chat box. Is there any more questions? We've got about 5 minutes before 12.
This is Lucy again. Dr. Furst, you know that I'm going to go to your neck of the wood toward LAX. When sleeping at people's house like that, do I have to wear a mask still?
No. Impossible. It just is not going to happen.
Yeah,
yes, we'd like that. But I think one thing you can do is try and keep a window open a little bit just to get a little bit better circulation.
Okay, that's what I did when I went to Mormon Lake in Arizona, and we had to stay in a cabin last September. We all wore masks. There was like 6 ladies in a cabin I stayed in. We all wore masks and we social distanced. And what we decided that we're not going to mess around and get close to each other. So we said, okay, we're going to wear a mask at bedtime.
Right. I sympathize with that. I don't know how people can sleep with that mask, but the fact is that people do when they do CPAPs. Nevertheless, I think, let's be reasonable here.
Okay, and don't get close to each other.
Try not to.
Yeah.
These all-night orgies, no, not right now.
No, thanks. No, not for me. Thank you, Dr. Furst.
Okay.
Sandra typed that she has a question. Sandra, can you unmute? And good to see you, by the way, that you came.
Hi, good to see everyone too. Thank you so much. I did have a question for the doctor. Most specifically, I do have kidney failure and I'm about to see my doctor. I haven't seen a doctor in a while. I'm sure a lot of us haven't because of COVID. And obviously the question is the vaccine. Do I take it? But to the doctor today, I want to know, after I see my doctor and after the blood work, what is it that I look at the blood work to know, am I safe to take this vaccine? Because I'm pretty healthy right now. And I want to see from the charts that he presented to us and kind of compare it to what I look like on paper and see, okay, should I take it? Am I risk high? Am I risk low? How do I know?
Couple of things you can do. First, look at inflammatory markers, ESR, CRP. Second, look at what your lung has been doing over the last period of time that you've done it, over the last year or so. Third, look at an echocardiogram and a high-resolution CT scan to make sure that despite the dialysis, your lungs and heart are doing well. All of those being stable and your renal function apparently being whatever it is on dialysis. Under those circumstances, I think a vaccine is very, very reasonable and is highly unlikely to cause you any trouble.
Okay, awesome. Well, good to know. Thank you so much. Thank you.
Sure.
Thank you, Dr. Furst. Okay, I think that's about it. I think we've answered everything. Again, guys, we'll be giving you all a copy of this, and we'll be sending the recording to all the support group leaders so we can have them share it with any members that weren't able to come today. And I hope some of you will look into coming to our peer meetings also, because this is such a wonderful opportunity for us to all talk. I want to say thank you, Dr. Furst, so much for taking this time out of your very busy schedule, very short notice, a week, guys. And we reached out to him, and then within, like I said, a snap of a finger, he agreed to do this, and we put this together. And we weren't even sure how many people we were going to get within a week. And, we had a lot of registrations today. So again, we want you to know how much we appreciate your time, and that you care enough about this population and our families that are concerned about the vaccine and the new information that you've been able to share today.
Well, really good to see you all online. Take good care of yourself.